So, hi everyone, and welcome again to the session. Session on anatomy, and welcome to the Auricle platform. And I'm your anatomy faculty, your friend, your educator over here, Dr. Ankit, and we are in the mid of the session, and we are dealing with the upper limb. Okay, this is a 21-day quick revision of Auricle. So it's a 21-day revision series, and we will dealing the upper limb, that is part 3 over here, right? Part 3 being 24th December. The questions I'll just show you what are the various questions that we are going to discuss today. You can even use the code below for various discounts on subscriptions. Here are all the salient features of Auricle, and it is comprising of all the classes recordings, plus we have the practical sessions, we have the hard copy notes, we have the express exam modules, all that. Here you can see all of that. Lastly, here we have this subscription plans. And from 3 months time period, that is a foundation plan, to advanced learning, complete learning, ultimate MBBS. So we have 3 months, 6 months, a year, and a 4-year plan. And you can see of all the facilities being provided over here. In the last two plans, that is for the 12 months and the 4 years, only in these two plans, we have a hard copy note set, and as well as a one-to-one doubt clearing session as well. And these are all the packages, and you can use the code always below, as already told, for any discounts. Okay, let's come to the topic. The topic is this is our third session on the upper limb. Which session? This is the third session on the upper limb over here, and we have discussed for a couple of days quite a number of topics. What we are going to touch today is based on these few of the questionnaires that you can see on the screen now. This is about the analyze the functional anatomy, and let me use highlighter for a second, of the hand. So yeah, questions do come from the hand, the anatomy of the hand, or you can say the functional anatomy, because as I always say, every part of anatomy, you have to correlate it with the functional or the clinical or the practical aspect. So describe the anatomy of the hand, telling about everything about it, bones, joint, muscles, and also we will discuss the palm and the hand region in detail. And the type of questions that can come is around the wrist, because again, these are practically very important, mostly in cases of sports injuries, or yeah, mainly in sports injuries and in accidents also. We have this this wrist problems, pain over here or any fractures over here. So therefore we have the retinaculars around the wrist, which are actually the deep fascias, as we might be knowing, that are holding the tendons, right? So anatomy of that. Then obviously the forearm muscles, because this whole compartment forearm, whatever activities we are doing from our upper limb, you can see whenever we move our hand, this forearm muscles over here, they are very important, and therefore we'll see them. As well as again, clinically or practically very important, the role of these three major nerves, right? So relevant anatomy of it and practical aspect of it, so that we'll see in the session. Then another question like this, we have seen anatomical stomach box. Yeah, there's one more thing, triangular fibrocartilage, we'll mention it. This is basically your basically when we talk of the wrist joint. So when you study the anatomy of the wrist joint, then there's a triangular fibrocartilage complex. It comes into play. It's actually distal to the lower end of ulna. So it is between the ulna and the carpals. We have this complex over here. Okay, then we have the thenar hypothenar muscle that will come in our anatomy of the hand. So guys, these are some of the topics that we are going to discuss. So today's session is going to be a bit intense, to be honest, and be with me. We just go through random and just quick revision, and in between I will show you some tips and all, how to write in the exam, draw. There will be a lot of diagrams over here, but obviously not all you can draw, but some will be there for understanding, some will be there so that you can replicate it in the exam hall after practicing. Okay, as I always say, during making of the diagrams, focus more on the labelings than on the beautification process. Okay, focus on that. So what are the important labelings? Every diagram, at least 5-6 labelings minimum should be there, so that it gives a good context of the theory written that you've written in the answers. So remember that labeling is very important. Okay, let us move on, and let's start with the forearm, basically the flex of the forearm, or the forearm per se over here. Just a second. Right over here. Right. So forearm bones, as we all know that lateral we have the bone that is the radius, and on the medial aspect, 1 second, on the medial aspect, which bone we have? We have the ulna over here, right? So on the medial aspect, we will have the bone that is the ulna over here. In these two bones, if I just put an arrow over here and ask you which bone is this, think about it. Which one is it? It's going lower end, you can see it's wide, fine. Upper end, you can see over here, circular head structure. This is the radius. Yes or no? Other one with a big upper end, this is the ulna over here. Remember, over here also you can see in this image, and between these two we have the interosseous membrane. So forearm, we have these two bones, radius and ulna, and we have therefore two compartments. One compartment lies in front, that is the anterior compartment. So always do remember, if you have a long question, then you start with the forearm bones. Forearm, from where to where does it lie? It is from elbow to the wrist. It has two bones, it has an interosseous membrane, and there are two compartments, an anterior or a flexor compartment. Do remember, and it also has a posterior or the extensor compartment. Okay, just to begin with, we can go with like this. Then we have some of the fascias over here. Obviously, do remember, we have two major fascias. One is the superficial and deep fascia in our entire human anatomy, or human body over there. But this deep fascia is quite important in case of limbs. Therefore, this deep fascia becomes very important in case of limbs. And it's as you know from the general anatomy, it's a strong fascia. It's a tough fascia. It's a strong or a tough fascia. Therefore, if there is any blood or any fluid accumulation in the upper limb or lower limb, it is very tight. It is very painful. Do remember that. So everything has some of the other clinical correlation attached to it. You have to figure it out. So deep fascias practically are very important in case of limbs, because if there's any fluid accumulation inside, it's very painful. And also it can be very detrimental for the entire limb. So what is the ideal solution? You can't give any medicine. You have to cut the fascia so that the fluid or the blood or whatever is there, pus and all that comes out. So that the pressure is relieved. Do remember that. And that is what is known as compartment syndrome. It is more important in lower limb, but it can be there in upper limb as well. So remember this clinical applied over here. This is how you can expand your answers. Let's move forward. Just a second, guys. Right over here, yeah. So bones over here, we have the, when we are talking about the forearm compartments, we have an anterior compartment and a posterior compartment. Okay, anterior compartment is also known as the flexor compartment. So anterior or flexor, don't forget it. Posterior compartment is known as extensor compartment. Okay, now what does it flex? What does it extend? Is it flexion of the elbow and extension of the elbow, or is it some other flexion, or is it flexion of the wrist or extension of the wrist? Point to be noted over here. When we are dealing with the compartments of the forearm, we are saying anterior, posterior, or flexor compartment and extensor. That flexor is flexing which joint? That we have to understand that that flexor and extensor is actually working at the wrist area, wrist region. So when you flex the wrist tightly, you feel the tightness in front of the forearm. And when you extend the wrist, then you feel tightness behind. And here they are showing in humerus lower end, we have a lateral epicondyle. This is lateral aspect, this is medial aspect. You can see the thumb over here. So lateral epicondyle over here, it is actually known as common extensor origin, CU, where you have the extensor which are coming out from it. Don't forget that. Okay, one point is this. Similarly, on the medial epicondyle over here, we have the attachment of flexor. It is known as from the common flexor origin. This you can do practically. Just flex and extend the wrist and feel the tightness or feel the movement at which part of the lower end of humerus. Okay, so do remember this. Now here, we have done that in detail previously also, but just again to show you these sort of diagrams you can make, guys. You can, when you don't have to be very artistic while drawing phalanges, you can simply draw phalanges like this. Then you have the metacarpals and carpal just to show what are the various carpal bones, how they are localized. The mnemonic for carpal bones is obviously important. She looks too pretty, try to catch her. Do remember what is lateral, what is medial, which row is pretty is lying proximally, and when you are catching, it is lying distally. Okay, pretty means this scaphoid, lunate, triquetral pisiform, they are in a proximal row. Okay, so pretty P for proximal. Yeah, that is good. P for pretty, P for pisiform, P for proximal row. And the remaining one obviously is TTCHS, the distal row. Okay, don't forget. And try to palpate as many as carpal bones so that you always remember that the pisiform, which is shaped like a very small P over here. Okay, it is like this, and you can feel it over here. Just let me try to, yes, oh, right over here. This is my pisiform over here in the left side. So it is on the medial aspect, and others are on the lateral aspect. Very important. Then now we come over here to look at the other things. like the flexor. So we'll start with the, just a second, we'll start with the flexor compartment, then come to the extensor. See, flexor compartment over here, there are few layers. Suppose the question comes on the flexor compartment of the forearm. What is the topic? Flexor compartment of the forearm. So we have multiple layers over here. We have a superficial layer, we have a deep layer, and also we have an intermediate layer, and they are muscles belonging to that area. That is what you have to answer. Understand this. How many muscles are there total in the flexor compartment of forearm? There are total 8 muscles in the flexor compartment of forearm. Okay. Deep we have 3, one we have intermediate, and superficial we have 4. So total we have around 8 muscles. What are these names? Should be absolutely clear. What you're seeing over here is the superficial layer. So how many muscles are shown? Pronator teres number 1 going laterally into the radius. Is the radius bone over here? Second number flexor carpi radialis. See where it is going on the lateral aspect. Okay, so it is ending where? At the base of the second metacarpal or end the carpals. Third muscle palmaris longus, it continues as what? It continues over here as the palmar aponeurosis. And then you have the flexor carpi ulnaris, which is going to the medial side. And this tendon gives rise to the pisiform bone. 4 muscles. Picture should be clear. From where to where we have to draw. And suppose they ask in more detail, always do remember that every muscle, what things you have to write. For each muscle, if they ask in a bit more detail, or you want to add some 2-3 lines, don't forget to mention for every muscle, O, origin, I, insertion, N is nerve supply, A is action. Origin, insertion, nerve supply, and action. These are mandatory. Then clinical applied, if you know, then you can add. But these 4 things are mandatory. These 4 things you can't go without it. If you want to explain, or the number of the question demands too much of explanation, then origin, insertion, nerve supply, action. Okay, draw it. So these are 4 muscles in the superficial layer. Let me just highlight this, that you remember what we actually dealing with. 4 superficial muscles over here. 1, 2, 3, 4. Okay, what is their action? Most of the muscles in the front or the interior or the flexor compartment is supplied by median nerve. 1.5 muscles supplied by ulnar nerve. Okay, that we'll see. Okay, here's another way to extend. This is not for you to make it. So this is for you to X. Remember, these are the 4 muscles. So if you keep your left palm on the right medial epicondyle, and just these, you hide the thumb over here, see 4 fingers, they represent these 4 superficial muscles. Next, let's go ahead. Again, these are another images, just images to show us these 4 superficial muscles. So the picture becomes clear. So then where are they inserting? Remember, pronator teres is going where? Pronator teres is ending over here. So will it act on the wrist joint? A W? No. Because it is not crossing the wrist. These are crossing the wrist. So they will act at the wrist joint. Common sense. Common sense. This ulnar is supplied by ulnar nerve, other supplied by median nerve. Let's move ahead. Okay, now intermediate layer. The second layer is intermediate layer. There is only one muscle which is quite spread out in the intermediate layer. I said, no, 4, 1, and 3. This is one intermediate, that is flexor digitorum superficialis. And you can see it is spreading out into the 4 tendons going to these 4, or you can say the medial 4 digits. And where does the tendon insert? Actually, that is also important clinically. Inserts into the middle phalanx, not into the, so FDS tendon inserts into the middle phalanx. So when you flex the phalanx, the proximal interphalangeal joint, its flexion is done by FDS, not the DIP joint. This is the PIP joint, this is DIP, D for distal interphalangeal, PIP proximal. FDS is only acting at the PIP, not at the DIP. And FDS supplied at which nerve? It's quite a big muscle, huge muscle. You can see how much spread out, because it ultimately goes into, it divides into 4 tendons. So remember, this is an intermediate layer. Okay, so just an example over here, just for the explanation. FDS, we origin, insertion. You can just read it. That's the theory part. I'm not going in detail, but yeah, theory, we have humeral head, ulnar head, radial head, but it's come out through a very diverse area. Then after that, we have the nerve supplied action. So these 4 things, as I already told you, just for example of FDS muscle, this is also known as sublimus muscle. And the name is FDS, also known as sublimus muscle. Fine. But these are some of the 4 things that you need to write. What does it do? So it is flexing the middle phalanx of finger, flexes the proximal phalanx, weak. It does not flex the distal phalanx of finger. It is only acting at PIP. It does not activate DIP. Do remember that. Okay. Next, here we can see over here. Yeah. So this again, yeah, this is for the FDP tendon. That you'll see FDP is a muscle of the deep layer. Okay, we have three muscles in the deep layer. So FDP is reaching the distal phalanx. FDP is reaching the distal phalanx. Okay. So FDP is reaching the distal phalanx. So it can flex the DIP. So FDP can flex the DIP. We'll see it later on. But this is the FDS tendon over here. Just, yeah, you can see the FDS over here. Where it is reaching the middle phalanx. That's it. Here also you can see the FDS tendon reaching the middle phalanx. That you understand it. Okay, now just a table over here, so you can just note it down or you can take a screenshot of this. What are the various wrist flexors? Sometimes these sort of questions come. So whichever tendon is passing in front of wrist, in front, they are basically causing the wrist flexion. So we have flexor carpi, ulnaris, and radialis. We have FDS, FDP, but sir, they are going to fingers. Yes, but aren't they crossing the wrist joint in front? Yes, sir. PL is what? Palmaris longus. So these are all the wrist flexors. Okay, now see, wrist joint is which type of joint? It is ellipsoid variety. It is not a uniaxial joint. It is a biaxial joint. So wrist does a flexion extension and also abduction adduction. So here you can see another group of the topic over here, which are the wrist adductors and abductors. So see, thumb is lying outside laterally. So movement towards the thumb, this movement is abduction. So it is FCR. FCR is wrist abductor. And FCU is the wrist adductor. But they are, so the question should come to your mind, or if you know the answer, then very good, proud of you guys. But understand, this is an incomplete answer. Why? If I ask you, there's more addition to the wrist adduction muscles. But sir, which one? Well, this adduction, this is wrist adduction. Thumb, little finger, this is wrist adduction. FCU, but also on the posterior side. So wrist adduction is flexor carpi ulnaris plus extensor carpi ulnaris. Start. Similarly, wrist abductor is flexor carpi radialis plus extensor carpi radialis longus and extensor carpi radialis brevis. Listen to this point. Because it's a 2D thing, no? Yeah, we are only dealing with the tendons lying in front. What about tendons lying behind? That will also come into picture. So remember that. Okay, just to show you flexion extension, just for your understanding. These are something that you can also make. It can give you ideas. What is adduction, abduction that we have seen? And now the deep muscles. So we are left with our deep muscles. How many muscles were there in the deep muscles? We had three muscles. And sir, okay, what are those three muscles? Three muscles are FDP, we have seen. It goes to the distal phalanx. Flexor pollicis longus goes to the distal phalanx of the thumb. Okay. And finally, we have pronator quadratus does pronation. It will not cross the wrist joint. Remember these three muscles. Okay, but sir, which nerve supplies them? Let me also tell you. This FPL is supplied by anterior interosseous nerve, that is a branch of median nerve. Pronator quadratus again supplied by anterior interosseous nerve, branch of median nerve. FDP is a hybrid muscle. Like we have various hybrid vehicles also, no? Right now we have hybrid cars. So it is a hybrid muscle. What are hybrid vehicles? Runs on the fuel that is a petrol diesel and also runs on even the electric mode or CNG mode, whatever you can say, right? The mixture. So therefore, what is the hybrid muscle over here? Hybrid muscle is actually having the two nerve supply. So the muscle has two sources of current. Like the engine of the car has two sources of the current going to the motor or whatever is fueling the motor, be it a petrol diesel or be it electric or some other source. Similarly, here we have what is hybrid muscle over here? The two nerve supply. So the lateral part of the muscle is supplied by the anterior interosseous nerve, while the medial part of the muscle or medial half of the muscle is supplied by ulnar nerve. So we have two nerves over here. Remember, that is a hybrid muscle. Okay, let us see some images over here. And this, I guess we have done. Right. So a bit of nerves over here. A bit of nerves. So you'll see the most images will come over here. A bit of nerves. Which area is this? This is front of the elbow or region of cubital fossa. This is the region of the cubital fossa. So a couple of nerves that you're seeing over here, not couple, but three nerves are what we are seeing over here. Let me just highlight it. One is this median nerve encircled already. See, it is going between two heads of which muscle? Pronator teres. So median nerve passes through the two heads of pronator teres muscle. Then we have lateral side with the radial nerve, as you can see. And the radial nerve will divide into deep branch and a superficial branch. That is a different thing that we'll see later on. And lastly, one over here is also, don't miss the ulnar nerves. These are three very important nerves, and their position in the region around the elbow or the cubital fossa. Ulnar nerve is running behind what? Behind the medial epicondyle. So basically, the ulnar nerve, it runs behind medial epicondyle. Behind medial epicondyle, right? Let us see more. Here's the flowchart, guys. This is one of my favorite things. This is, I guess, from a book known as Snell's Clinical Anatomy. This is right for median radial ulnar nerve. We have the flowcharts. Okay, so see, beautifully, they have made median nerve showing all the root values over here. These are the root values. I would ask you to take the screenshot of this if you don't have, and just try to understand. Okay, and see what is happening. This region is the region of axilla. You can see this dotted line, so it is between these two we have axilla. And between these two lines, what we have the region of arm. So in the arm, it does not supply any muscle. Why, sir? Because front of arm by musculocutaneous nerve, back of arm by radial nerve. So where is median nerve over there? Nothing, doesn't apply much. But yes, at the lower part does give a branch to pointer teres. Then you see over here, this is the region of what? This is the region of forearm. This is the region, and you can see we are dealing with forearm right now because we are not showing us most of the hand, because there will be hand branches also distally. But look at the forearm, how many muscles does it supply? Pointer teres, FCR, palmaris longus, FDS, flexor digital profundus, only lateral half, because it was a hybrid muscle. Pointer cortex also. Why? Because this is the entry in torsions. Now let me just try to show you what is actually happening. We have this median nerve to begin with, but then over here it divides into the entry in torsions, which will supply the deep muscles. All these three muscles are deep muscles, while the core of it supplies these superficial and the intermediate muscles. So median nerve mainly supplies the forearm, so it is known as the laborer's nerve. What is it known as? But also you have to write that this median nerve is known as the laborer's nerve. Why we call it laborers? Because laborers normally use the hardcore strength of the forearm while doing any labor work. Therefore, as those muscles all are supplied by the median nerve has been traditionally called as the laborer's. While if you see the distally in the hand, it is the ulnar nerve that is supplying more of the muscles of the ulnar nerve. So what name do we give it? Or which nerve is, do we also call it the ulnar nerve? We call also, it is famous with the word musician's nerve, because hand movement, finger movements, musician nerve. Okay, see over here, ulnar nerve, musician nerve. These all things you have to write and make it in bold or make it a small box, something in your theory paper. Okay, so remember that. Here the simple course of the learner is being shown. It is going behind this medial epicondyle understanding. Therefore, fractures over here, that is the applied part, can easily damage the learner. Then see what it is doing. It is passing between the heads of flexor carpi alaris, supplying it. Then it will go down, and then ultimately it is going down into the hand, that we'll see later on. Okay. So this is the ulna over here. And here again, this is an image from the Snell's book, just to show you some of the neurovascular bundles over here. So if you want, you can take the screenshot, but let me just highlight 3-4 things over here that you can go with it and understand few things. Like, for example, look at the median nerve and focus on the, one second, on this deep branch of radial nerve that is going on the extensor side of forearm. Okay, and then we have this, look at the brachial artery, how it is dividing into the radial artery and the ulnar artery. Okay, and here from somewhere over here we have this coming out as a median nerve over here. This is a median nerve over here. Sorry, ulnar nerve, not median was out there. This is ulnar nerve going medially, and this is the same median nerve. You can see the median nerve at over here, and it is going down over here, just to show some of the neurovascular structures. Okay, now some of the branches of ulnar nerves, just for your understanding, this is not for your making. If you want, you can make, but do remember that ulnar nerve over here divides into a dorsal branch and a palmar branch for the hand, actually, because ulnar nerve is the musician nerve. It is a musician nerve. So ulnar nerve's basic or major role is there in the hand. Okay. Forearm main nerve is median, main, not all. Hand or palm main nerve is ulnar nerve. Arm, front of arm, main nerve is musculocutaneous. Everything posterior is radial nerve. So see, half of the upper limb is already finished. Just if you keep one thing in your mind, that posterior part of my upper limb or any upper limb is mainly innervated by the radial nerve. because it is the largest branch of brachial plexus also. But if we talk of the anterior part of the upper limb, this is musculocutaneous, this is median, and this is ulnar. Main contributors. Keep that in mind, and your life will be very easy for upper limb. Okay. This is sort of similar flowchart for the ulnar. Look at this root value, only this. Look what it is supplying in the arm. More or less nothing in the arm. This is the upper arm on the or the arm region. In the forearm also, see what is it supplying. Only how many muscles I told you? 1.5 muscles. So where is one? One is this. Where is half? Half is this. That's all. The rest it will go and supply main muscles in the palm. That's it. Because these sort of flowcharts can actually make it. It's not difficult, obviously. Just practice it a couple of times, and you're good to go. Radial nerve has been trying to. These sort of images are same. Just try to draw them for a couple of times, and then look at the two divisions of radial nerve. Radial nerve is basically supplying the posterior side, but in the cubital fossa, it lies on the anterior aspect around the cubital fossa. Okay, for a short time. Then what actually happens is over here it divides. Over here it divides at this area into a deeper branch of radial nerve that is known as posterior interosseous nerve, also known as PIN, and a superficial branch of radial. This is actually has a cutaneous distribution, as you will see later on. While this posterior interosseous nerve is going to supply the extensor forearm muscles. Then, sir, what will radial nerve do? Radial nerve itself will supply the extensor arm muscles, the triceps, the brachioradialis. Then you have the supinators. Okay, we have the ECRL. So you'll see we have a mnemonic over here. Radial nerve supplies best muscle. 4 muscles over here, and best. We'll see later on. Understand the basic concept. Radial nerve is supplying the extensors of the arm. It gives off a deep branch that is also known as posterior interosseous nerve. But what does it supply? It supplies the extensors of forearm. That's it. Here we don't have muscles. Here we have the tendons only. You might be thinking, when it's a palm we have, why not here? Here you can feel it. Do you have any muscles? No, we have mainly you can feel the bones and the tendons. And this is the cutaneous part, the superficial branch of radial nerve. Let's move forward. Here are the other images showing us the branches. Again, the same thing, radial nerve dividing into these two branches. Not to repeat again, this is sort of repetition image. Okay. So that we have already done, the flexors and pronators of the forearm, anterior compartment, median nerve, and 1.5 exceptions, that was medial nerve. So done and dusted. Extensor of forearm posterior by the radial nerve directly or by its deep branch, that is PIN, posterior interosseous. Let's move ahead. This is for the palm area, showing us some of the important, these are synovial sheaths. What are these? These are basically the bursas over here. What are bursa? Bursa is some supposedly a sort of cushion or a greasy material. So once you rub against like this, you're holding hand tight, you're holding the suitcase tight thing and you're lifting it up at 10 kilos, 20 kilos, whatever it is, or you're doing any exercises in gymnasiums. Then those heavy weights, they don't crush your tendon or the bones. Understand this? Because you have a tough fascia over here and all those tendons are protected by the synovial sheaths, which are known as bursas over here. As you can see, nearly all the tendons, you can see this light blue color. These are all the synovial sheaths, also known as ulnar bursa on the middle side. A radial bursa will be there on the lateral side. These come in questions. That question can come as what tendons do they actually cover up? So radial bursa will cover up FPL, flexor pulsus longus tendon. Ulnar bursa will cover up mainly your FDPs and the FDS tendons, the distal profundus and superficialis, right? And these are distal synovial sheath, they will cover the same tendons, FDS and FDPs, mainly FDPs over here. So do remember that common flexor synovial sheath and this radial bursa over here. So even these come as a question. These come as a question. These will also, you will learn them in the clinical applied. We have the bursitis over here. What is the bursitis, sir? Inflammation of the bursa. Any thorn over here, any dust material or pathogen entered through the skin towards the bursa, bursa is inflamed. The bursa is inflamed, it will go approximately, it will inflame everything. And normally in 50% of cases, I'm telling you, documenting the anatomical status over here, 50% of cases, both the radial bursa and the ulnar bursa, they communicate. So infection over here or any bursa can transmit to the other one. And that infection can go proximally where? Into the forearm. Forearm, which space is there? There's also one question that comes as the space of perona. Do understand that also. If not, then viva can be I mean, whatever can be happen now over this small topic, or theory or question also come both in equal percentage. Perona's space. These bursas also important. Try to make them now. You can see over here one practical thing. Because you guys also study physiology, okay? And if you remember physiology, we had that hematology lab where we prick and take a drop of blood and make a slide of it, right? Remember? So once you're doing that, the residents over there tell you which fingers to use and which fingers not to use. They'll always say that don't mess up with the thumb or the little finger. Try to look for the middle or the ring finger. Why? Because you can see over here that for the thumb over here and the little finger over here, their bursas are continuing into the palm. So if by chance, God forbid, any infection happens in these two fingers, that infection will also trouble the entire anatomy of the palm. While for the middle or the ring finger, if God forbid any infection happens over here, it will limit it to this area on. Understand? Therefore, always advisable this. Why not index finger? Because again, no, thumb and index finger, they are very important for your daily, the sensation of proprioception to identify the stuff and whatever daily activities you do. Index finger is very much used compared to middle and the ring finger. Therefore, ring finger is preferred. The ring finger, then you can go with the middle finger. If then you can go with the index finger. Right. So that is anatomy plus physiology over here. See, here's the peroneal space. Can come as a question. Can come as a question. So at least these 4 or 5 lines, try to elaborate it. This is a peroneal space, subtendon space lying in the forearm. It's a forearm space of peroneal. So it's a space that lies between FPL FDP tendon lying in front and pointer quadratus lying behind. And above, SUP is a superiorly, not superficially, it is superiorly. It is limited by an oblique line. That is where the FDS takes origin. So above we have this oblique line. So it is limited by. In the forearm, it is between the FDS FDP muscle and a deeply lying pointer quadratus and interosseous membrane. It is this continuation of that. So pus in the FPL sheath can ascend into little bursa and eventually see. As I told you that part little ulnar bursa, and how they can enter into peroneal space. And these can be infected by problems in the thumb and the little finger. Understand? So problem started with here. And see, it can reach the palm as well as it can reach the forearm. Understand this. Therefore, these two are avoided. Okay, same thing over here. Now let us see the extensor compartment. Common extensor origin already told you. It's which condyle? It's a lateral epicondyle. It is our lateral epicondyle. Let's move forward. Extensor retinaculum, guys. Extensor retinaculum, this part over here, this is our extensor retinaculum. Right over here, it's slightly oblique, going down to the thumb side. This over here, if I place my 2 fingers over here, this is the extensor retinaculum. It is holding the tendons. So if I extend the wrist, the tendons, they don't pop out. Similarly, if I flex the wrist, the tendons, they are not popping out. Or they are actually not, even they are not folding the skin as well. But because they are held tightly, it is like a wristband. If you have ever played lawn tennis, or we have seen, obviously, you must have seen people playing lawn tennis in even the television. We have the Wimbledons, we have the French Opens, we have so many Opens over here. Even in India also we have quite a craze of the lawn tennis. So they wear wristbands. Why? Because they have that hard, strong racket. It is not a badminton racket, it is a strong racket. Even the badminton players also wear it. And then when the ball comes into force, they have to very forcefully return back the shot. In that you need a strong tendons over here. So it's a natural thing is we have the retinacula, but just to addition support it, we have the wristbands also. So normally you won't see everyone wearing wristbands because normally the God, who the creator of the human body, they already gave the wristband. That is the extensor retinacula over here and the flexor retinacula in front. Understand? Now, extensor retinacula over here is divided into 6 compartments, as you can see over here. The numbering from 1 to 6 over here. This always remember the numbering starts from the lateral side, that is the thumb side. And it will end where? Obviously on the little finger side. Now, what actually can come as a question is what are the various tendons lying in the single sheath, or diagram you can make that you will see. This is again the extensor retinacula. So a bit of theory of extensor retinacula. It is a deep fascia. I already told you. It is attached on the lateral medial side. This is mainly bony points. Surgically, it becomes important. It is lateral to the radius. If it lies below and middle to it goes to the triquetral bone. Bit oblique over here. 6 fibrous compartments, and therefore this 6 fibrous compartments, which are actually over here, we'll see in a while that what are the various tendons that lie in 6 compartments over here. Now let's come to the extensor forearm muscles. How to remember it, sir? There are so much. Yes, there are so much. To begin with, 3 things that you have to understand. What are those? One group of muscles will extend the wrist. What are that? That we have seen ECRL, ECRB, ECU, these 3 muscles. So this will help in adduction, and these 2 will help in abduction. If you remember what I'm trying to say, adduction, abduction of what? Adduction, abduction of the wrist. Yes or no? So one group of muscle is extending the wrist. One group of muscle is extending the fingers, extending the digits except thumb, like extensor digitorum, extensor digiti minimi. Even one addition over here will be extensor indicis, which is written over here. Clear? So one group is extending the wrist, one group is extending the fingers, and one group is extending the thumb. Because thumb is quite different from the other these fingers. Remember cutting the thumb. Okay, this Mahabharata and all. Okay. Because thumb we have special tendons because thumb is a very different to compared to the other fingers. We have more movements. The joint over here is saddle joint. The joint for the first CMC joint, first carpometacarpal joint is saddle joint. It is multi-axial. So we have all these. We have pollicis muscle, abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis, all this, and these all will pass through the wrist area. And these tendons are the ones which are divided from 1 to 6. So 6 over here and 1 over here. So there are 3 groups lying mainly in the superficial part of the forearm. Extension of the wrist, extension of the fingers, extension of the thumb. Simple as that. Here was the mnemonic as I told you. So box making, this will help you in theory exams also, how to draw it, right? So radial nerves innervates the best muscles, P, E, S, and T. T for triceps brachial. Let's move forward. Again, this sort of similar thing shown in the image, just for your understanding. Okay, just a second, guys. Let me just check. Yeah, am I audible? Is it going? Just a second. Let me see. I hope it is. Right. So let us continue over here. Just a small power problem. Yeah. So these are all the tendons again. Okay, just tendons. You can make if you want some, but else you can just avoid. But if you practice, you can make it. Not a big deal. Just remember the 3 things. What is extending basically of the wrist, then extension basically of the fingers, then extension basically of the thumb. And here you can remember mainly all the muscles. But are there some other muscles? Yes, some other muscles are there left. We'll see in a while some other bit of deep muscles we can say, like for example, a supinator. Okay, that will lie posteriorly. So deep posterior compartment will have these muscles, deep posterior compartment. If you look at this image also to begin with, what are the muscles that are lying more deeper, which are popping out? These muscles are popping out, no, they are lying a bit deep. So therefore, we have this deep muscles over here. Then a couple of more indices and supinator. Let us see over here. Look at the indices, extensor indices. Where is extensor indices? You can see these 2 tendons over here. One is digitorum, one is indices. Was going to the index finger. So out of these 3 extensor indices and supinator, you can't see it over here. These are lying, or these are covered by the other muscles. So therefore, these are lying in these are said to be lying in the deep posterior compartment. While which nerve is supplying all of them? PIN, posterior interosseous nerve. All of them. Except best, you remember, best supplied by the radial. So it will extend this, and supinator will do what? It will supinate. What is supinate? Bagger supinate, if you remember. Can you go like this? Again, a similar image. Yeah, one more question can come, or do come. It is very, very important. I will give 3 stars. It's a dorsal digital expansion. This diagram you have to practice, guys. Okay, you have to not do much, but let me highlight over here what is actually happening. Try to understand. This is the extensor tendon. Which extensor? Extensor digitorum tendon mainly. And once it reaches the distal part of the metacarpal, now let me show you practically over here. You can see some tendons over here. Just extend the fingers, you'll feel some tendons over here. But as you trace the tendons, once you come to the dorsal side of the fingers, you can't trace the entire tendon. So suddenly the tendon gets lost. Why? Because it spreads out. It spreads out, and the other muscles like the lumbricals and the interosseous over here, they join it. and it spreads out. And then we have some slips. We have a central slip and we have the collateral or the lateral slips. They will insert into the middle and the distal phalanx. So you can feel the tendon over here at the MCP joint, the extensor tendon. But once you try to trace them, no, gone. Then they are not felt because of this dorsal distal expansion. And why is this? This is because other tendons also have to join it. And why do they have to join it? Let me tell you that also clinically. Suppose you are doing any activity with your hand. Suppose you flex your, what we say, the MCP joint or the wrist joint. Suddenly, everything needs to be flexed. Okay, but it is not always the case. You can even extend the fingers and you can flex the MCP joint and the wrist joint like this. All these movements gives a lot of efficiency to the fingers. Okay, this is the action of lumbricals. The lumbricals will do what? They will flex at the MCP, they will extend at the IP joint. Similarly, the interossei, they do adduction and abduction of the fingers. So extensor digitorum basically acts at the MCP joint only. If you're thinking that the extensor digitorum is extending the IP joints of fingers, no. The IP joint of fingers are basically extended by the lumbricals and interossei. Understand that. So extensor digitorum tendon is basically acting where? At the MCP joint only, practically. And as you go distal from here, it is the lumbricals or the interossei who are extending the IP joint, interphalangeal joint. Remember this point. So this anatomy of it, on the distal end of the metacarpals, the four tendons flatten to form extensor expansions, as you can see over here. Okay, now coming back to the groups, I guess we have seen the groups. Groups again, superficially, you can see this brachioradialis and all these extensor tendons. So what was in the deep? If I just change the pen over here, what was lying in the deep part? Deep part were the extensors of the thumb. Then we had extensor indices and we had supinator. So whatever is left is lying in the superficial group. One more clinical applied in between, elbow, tennis elbow. Remember our Bharat Ratna awarded one of the, or we can say the arguably or unarguably the greatest batsman of all time, Sachin Tendulkar. He had this problem a couple of decades back. I'm not sure of which time, but somewhere I guess around 2002, 2004, he had that lateral epicondylitis, somewhat. Right? So what is that over here? It's a painful situation. So when you have this repetitive use of the extensor tendons, you have the pain in the lateral epicondyle. Obviously, when you're holding the bat, and we all know if you follow this, if you follow those the cricketers, mainly the batsmen, they keep on practicing. Once you're practicing with the heavy bat, and Sachin was famous for using heavy bat. Because he's practicing heavy bat, you extend. See, elbow, your position is this, right? So your elbows are flexed, and you're playing a shot, you have to extend. Basically, you're extending with the weight in your hand. So what will happen? As repeated use of extensor muscles leads to this problem, lateral epicondylitis, also known as the tennis elbow. And if it happens where on the medial epicondyle, then what we'll call it as? It is a medial side problem. We call it as golfer's elbow. This is again very, very important clinical applied that you can add on. Okay, just to show you the action of the supinator muscles over here. Second, right. Yes, supination, pronation, done. These are some of the deep muscles. So what we are seeing over here, deep muscles, abductor pollicis longus, pollicis brevis. Then we have this abductor pollicis longus done over here, extensor pollicis longus over here. Okay, we have the supinator part over here, extensor indicis over here. These are all lying deep. I guess we have done this topic a couple of more times. I'm not going to repeat it again, but this image was a bit different. So I just intentionally today, for your understanding only, place this image. This is, guys, over this area is the anatomical snuffbox. This is the lateral boundary. This is the medial boundary. If you remember, medial boundary by which tendon? EPL was medially, and these two were lying laterally. This is the anatomical snuff box. This is the anatomical snuff box over here. Okay, just for this a part of understanding, I'm not going to repeat it. Radial nerve we have seen, posterior interosseous nerve, just for your understanding this. You can see over here how it is dividing, how the radial nerve divides into these two. This deep branch on the lateral view, this is the posterior view actually, posterior view if you see in this image. You'll see this posterior interosseous nerve, yellow color now coming down and supplying more or less all the muscles over here. as I told, the third flow chart over here for the radial nerve. And you can see it is supplying all the things in the arm. It is supplying in the forearm, but which compartment? POST, posterior compartment. Well, okay, giving a lot of cutaneous branches, giving a lot of other branches, but it's a awesome nerve, right? Which is doing so much of its work. Therefore, its palsy, its paralysis also becomes very important. That will see in a while. You have to see in a while. Just yeah. Here are the 6 tendons. Just take a screenshot of it. And how to remember it, sir? How to let me tell you? See, number 1 was first compartment was lying laterally. That is, it was lying towards the thumb side. Yes or no? Yes, sir. This 6 was lying towards the little finger side. Yes or no? Yes, sir. Okay. Look at their names: carpi ulnaris, digiti minimi. So remembered by DC. They lie 6 and 6 compartment. Number 1 and number 3 compartment, they are the boundaries of anatomical snuff box. Abductor walls is longer, external walls is brevis, and external walls is longer. So how many compartments over? We had done with compartment number 1, 3, 5, and 6. Let me change the color over here. So compartment 1, 3, anatomical snuff box. 5, 6 is DC, digiti minimi, and C for carpi ulnaris. Okay, all are extensors. All are extensors. What are left? Number 2 and number 4 compartment. Only 2 are left. Number 2, we have 2 tendons over here, ECRL, ECR. For how to remember, sir? This is bit R, radialis, going laterally. Again, close to the number 1, right? Radialis, so it is close to the number 1. Why number 1? Because lateral side, lateral, radial, radial. Left is number 4. Number 4 is somewhere in the middle, so we have extensor digitorum, extensor indicis, somewhere in the middle, right? It is not either 1, 2, nor 5, 6, somewhere in the middle. So it has extensor digitorum, extensor indicis. Remember these names, they can come as a question in your theory. Diagram, make tendons, write it carefully, nicely, nice, tidy. You will get 4 out of 5 minimum. Okay. Yeah, in the image over here, just to show you the flexor tendons. Yeah, just remember the palmar interossei pad over here, because it causes adduction of the fingers, supplied by ulnar nerve because they are the hand muscles. What was that? They are long flexor tendons over here. Dorsal interossei dab, it causes abduction, again supplied by the ulnar nerve. And dorsal interossei, they are bipinnate. They are more powerful than palmar interossei. They are unipinnate. Look at the muscles. Look at the palmar interossei. Look at the double-edged sword. It's like a leaf, right? It's like a leaf. So that is what is actually the bipinnate. Go to general anatomy, guys. You guys go through these exams. I would again urge all of you. This is very important advice. After giving all these exams that you are having the terminals, open up your Cunningham manual, or also known as a dissector, Cunningham's manual, anatomy. And for that, the first 20 pages in volume 1, general anatomy is given over there. That is very important. Read it slowly and understand it. Again, if you have not read it, please, highly advisable. If you have read it, revise it. Cunningham's, I guess, the first 20 pages. 1 or 2 pages plus or minus, but first chapter, first 20 pages. Volume 1, I guess. Where the general anatomy is given, muscle, nerve, bone, joints, very concise, but a very good quality material is over there. Do read it. Now supply of hand again. So this is the, what we say, the dorsum of the hand. And medial side, this is ulnar nerve. Lateral side, this is radial nerve. And the fingertips by the median. So all these 3 nerves over here. So whichever nerve gets damaged, that takes into part. Again, Colles fracture is very, very important. Right at as applied, but clinical, let me tell you, 4 stars over here. For practical standpoint, when you see the OPDs, orthopedies, mode of injury, and there's this dinner fork deformity over here. The distal end goes backward, as you can see in the next slide. Most common fracture of the forearm, understand this. The distal fragment goes backward, dorsally upward. So it is like this dinner fork deformity. It's like a dinner fork deformity. If you see them from this side, this is the normal part, but in a Colles fracture, it will be like this, right? Like so, that becomes a bit like dinner fork deformity. Okay, radial nerve. See, injuries of radial nerve in axilla that come at many levels. One is in axilla, so that, let me use a highlighter. Ill-fitting crutches, axilla radial nerve problem. Okay, so crutch palsy and night palsy can be there. Then see over here, these are all the features of it. Okay, so really motor loss and wrist drop would be there. sensory changes will be there. Then there is a problem of retinal in the spinal groove. Where is spinal groove? Right in the mid shaft of the humerus. Then things will happen. Please take a screenshot of these, go through them. We can't discuss them all in detail, but yeah, these are important. And finally, we have injury to the deep branch, that is the posterior interosseous nerve. So basically, the whole nutshell is that, sir, how to remember all of this? Okay, which I'm going through. Some of you might be raising eyebrows. So what are you doing? So you are sitting. Understand. How to understand this? Understand that, remember that flow chart of the radial nerve. We divide it into axilla, then arm, forearm, and obviously hand. So this is AX axilla, this is ARM arm, this is forearm, and this is your hand region. Understand this nerve is coming down. What are the various branches where it will get? Simple as that. Okay, sir. Then what? I'm telling you, it's a one-time investment. If the injury is over here, all this is gone. Distal to it, all this is gone. If the injury is over here, okay, so proximally is fine, then distally is not fine. If the injury is over here, proximally is okay, distally not okay. Simple as that. Be it your motor or sensory changes. That is what you have to do, a one-time investment over here. Okay. Now let me show you a bit of the palm parts over here. So we have done just 2-3 topics left for the quick revision. So different film types, radial, lateral, skin, not going to discuss all of this. Yes, this image is important. This image is important. Why, sir? Because it is showing us what? It is showing us the TS over here. You can see these are the 4 carpals. Trapezium, trapezoid, capitate, hamate. Which row is this? This is the distal row. Very good. Proximal head pisiform, P for P. Proximal pisiform, pretty. Okay, so this is the distal. So therefore, anterior to it, this all thing anterior to it, this is all lying in the flexor side, and behind the carpal bones, all this is extensor side. Clear? Yes, sir. Clear. Very good. This you can see the thumb. So this is the lateral aspect. Yes, sir. This is finger number 1. Yes, this is finger number 5. Yes, this is medial aspect. Now see over here. Let me just put a highlight so that you can. This again, I guess from Snell's only. Beautiful diagrams, that book. We focus on the flexor retinaculum. Okay, green line, right? Now you can trace it. Yes. Now for the all this structure, let me use another highlighter. That which one to use? Right, this all these structures I'm highlighting now, they are actually between the carpals and the flexor retinaculum. Agreed? Yes, sir. Therefore, any injury to these or any injury to the flexor retinaculum, or also known as carpal tunnel syndrome, the CTS, carpal tunnel syndrome, all these structures are compressed, and mainly it is the median nerve that is involved in carpal tunnel syndrome. These are all the structures that lie deep to carpal tunnel syndrome, deep. Okay, then sir, what lies superficially? All these structures, they lie superficial to the flexor retinaculum. So flexor retinaculum forms a deep to it. You have structures over here. So these structures lying deep and these structures lying superficial. So when there's carpal tunnel syndrome, whenever there's carpal tunnel syndrome, the structures lying deep to the retinaculum, they actually at risk of getting compressed, and mainly it is the median. Similarly, on the extensor retinaculum, you can see all of it. This is the compartment number 1 over here, then compartment number 6 over here. Needless to discuss anything. But yeah, this image, try to draw it. So how can you do? Focus on labelings. If you know the 6 compartments, write them. If you know, okay, this FDS and FDP, they are all lying deep to the retinaculum. The FPL lying deep to the retinaculum. The ulnar nerve, right? The palmaris longus, they are lying superficial to the retinaculum. So you can write them in theory. Also, let me show you over here like this. The structure passing superficial to what? To flexor retinaculum. So what is the implication? So that in carpal tunnel syndrome, these are not involved. Okay. And so will there be, if a question asks you that there's a carpal tunnel syndrome, what is carpal tunnel syndrome? When the structure lying deep to the flexor retinaculum, there is some, could be any issue, it could be idiopathic when the structures lying deep to the retinaculum gets compressed. So will there be a sensory loss in the palm? You might say, yes, sir, if median nerve is compressed, whatever median nerve is supplying that, but look over here. Passing superficial, you have what? Point number 2, palmar cutaneous branch of median nerve. So palmar cutaneous branch of median nerve, it passes above the retinaculum. So sensation in the palmar side of the median nerve over here, that is normal. Sensation will be lost in the fingers and the motor loss will be there. Similarly, structures passing deep to what? Flexor retinaculum. These will be involved, and mainly it is this thing that gives rise to the signs and symptoms. And normally in old age females having diabetes, thyroid issue, even pregnancy can, or most of the times it is, can trace the cause, it is idiopathic. Why people are having this problem of carpal tunnel syndrome. Medicines can help, but if it's not helping, you have to do surgery, you have to cut the retinaculum, and you have to just, lift the pressure off so that median nerve is relaxed. That is what you have to do. Again, a bit of carpal tunnel syndrome. So burning pain, this is important. Burning pain or pins and needle sensation on the lateral 3.5 fingers, note over here, not the palm. Weakening and wasting of thenar muscles, because thenar muscles of the thumb, they are supplied by median nerve supplies. No paresthesia occurs over thenar eminence. Why? Because this eminence comes under the territory of palm. The condition is dramatically relieved by decompressing the tunnel by making an incision. So treatment is surgical through the flexor retinaculum. Simple answer. Dramatically improved. Okay, just like our compartment syndrome. One more applied, you can talk of the your dependence contracture over here. You can talk of the dependence contracture. What happens over here? Again, it's a this you can say thickening and the partial contraction of the your palmar fascia, or you can say the palmar aponeurosis. So fingers over here, mainly the ring and the little finger, as you can see in this image, it gets flexed. It gets a bit flexed. Okay. Now the hand muscles over here, hand muscles, we have the two compartments over here. Just remember, thenar compartment will have around 4 muscles. Hypothenar again 4 muscles. Lumbricals 4 muscles. Interossei have palmar and dorsal interossei, four muscles. How many muscles? 4 into 5 is 5 times 4 is 20. You have 20 intrinsic muscles of hands. 20 intrinsic muscles. Let me just try to show you quickly. These are the 4 thenar muscles. I can tell you what is the question that can come. Adductor pollicis over here is supplied by ulnar. Remember this. While these are mainly supplied by the median. Important questions over here for any type of exam. Okay. Movements of thumb, that is again practice, guys. Just try to practice. They can come as an image-based question. People can ask you, vivas. Even when you're giving your MCQ exam for various other next or NEET PG, can come as an image or can come as a small video as well. Understand this. Movements of thumb. Thenar muscles and hypothenar. In this image, you can see 3 hypothenar muscles. One more is a superficial muscle. And you can see over here the pollicis, that is the thenar muscles. One is missing, that will show you the name as well. Okay. Hypothenar muscles over here. One over here is this one is palmaris brevis. It is a bit superficial muscle. Then, if you include this, then we have the number 4. And they are supplied by the ulnar. I'll tell you how the ulnar nerve becomes the prominent nerve, because all the 8 interossei, again, let me go over here. Yeah, let me change the color and just try to tell you over here. This totally by ulnar, this totally by ulnar, this totally by ulnar. 1 over here is ulnar, and out of 4, 2 over here is ulnar. So you can see 1 plus 4, 5, 6, 7, 7 plus 8. There is around 15 muscles out of 20 approximately are supplied by ulnar. Which is not supplied by ulnar are the 3 pollicis muscles, then 2 your lumbricals. That is what. So 5 muscles are supplied by median nerve, 15 by ulnar. So basically what you will say, 3/4 by ulnar, simple maths. 15 out of 20 is 3/4. So when you say 75% of my hand muscles supplied by ulnar nerve, so ulnar nerve is therefore known as musician nerve. 75%, 15 out of 20. Okay. Hypothenar muscles, here long flexor tendons. Here you can see the lumbricals. The lumbrical, what happens is first and second lumbrical, they are supplied by median nerve, while these 2 lumbricals supplied by the ulnar. Okay, palmar interossei, ulnar nerve. Dorsal interossei, 4 and 4, 8 ulnar nerve. Now supply action again. Nerves of the palm. Yeah, this the sensory sensation again. We have repeated it again. Median nerve, ulnar nerve, radial nerve. Okay, so that also can come as a question. This we have already done, but this is now in the previous image of median nerve. We didn't solve the palm region. Here you are seeing the palm region. Okay, what the median nerve is doing in the palm region. This is a complete flow chart of the median nerve. Please take a screenshot and try to make it. Again, branches shown over here. This is just for understanding facial spaces in the palm. Yes, you can write out there. That can also come as a question. This is also a question. Palmar facial spaces. Elaborated. This, I guess, we have just talked about the bursas. Pulp spaces is at the pulp. Mid palmar thenar spaces. Let me show you. Yeah. This diagram also you can make over here. This one over here. Why, sir? Just to show you. Can you see this blue colored? Let me just highlight it a bit. That is this, right? Mid palmar space over here. And this must be the thenar space. Here, right. Focus on this labeling I am telling you. The spaces question comes, focus on this. Okay. Here also you can draw about the mid palmar and the thenar space in a frontal view. This is a TS view below. And this is the pulp space of the fingers. Bursas you already have seen. I'm just giving you hints, guys. Understand, practice these diagrams. Okay, try to understand also. These will be how you can approach over here. Okay, boundaries we have seen. Okay, yeah. So that was it. And let me just go back quickly. Just few more seconds. 5, 4, 3, 2, and 1. Okay, so understand this. Anatomy of the hand over here. Okay, anatomy of the hand over here. So questions can come from and hand. See, so many, as I said, spaces. Okay, then nerve supply, basically cutaneous, because all these are relevant clinically. Then carpal tunnel syndrome, very important question. Carpal tunnel syndrome, needless to say, anatomical snuff box in the hand only. Okay, in the hand only. Then dorsal digital expansion. Remember that extensor digital tendon. Then obviously the retinaculars, as we already have seen. Retinaculars. Okay. then if we move ahead, the retinacle is already dealt with. Muscles of forearm. Okay, remember at least the names and their nerve supply and origin insertion. Now, origin insertion, you can bluff 10-20%. And the upper 3/4, upper half, anterior border, the middle half, bluff 10-20%. But 80 to 90% should be clear. Okay. Then these nerves and all of them clinically applied. They're clinical. What happens when will they get injured? So that for this, guys, remember, if you are not able to recall everything, I hope you do, but actually remember their flow charts, especially I place them over here, so that you know which branch is where, so that you can understand, okay, if this muscle is paralyzed, what will happen? So at least you can write something. That's important, right? The snub box you have seen, this is a part of this joint. Okay, I hope you enjoyed the upper limb, and Merry Christmas again. Not again, but first time Merry Christmas. So tomorrow enjoy the Christmas holidays. And day after tomorrow we'll come with your thorax revision. But you have a day's time. Quickly revise upper limb, and any queries, let us know. Let me know. We'll try to help you guys. That's all. Bye-bye. Good night. Take care, guys. Thank you. Just a second.